Okay, Federica here has a question. Federica, I want to hear your voice. You can actually unmute and just,
Okay.
yeah, give it, please.
So, thanks for your presentation. It was wonderful. As I told you before, I work in Italy, in Sicily, and I must tell you that there is actually a bit of a reluctance among hepatologists in using LI-RADS system. We use it at our center, and it was really painful for them to accept it. And they told us that actually AASLD is published only a guidance paper, not a guideline paper, and that also LI-RADS is not a guideline paper, and that we should follow only guidelines paper and not guidance paper. Do you think that in the near future there would be the possibility to publish like sort of guidelines for LI-RADS instead of just a reporting system or an ASSLD guideline paper, joint paper with LI-RADS? Because this is, according to them, this is very, very important because they told me that the guidance is based on weaker published data compared to guidelines, and for them, it's they told me they prefer to use EASL or ASSLD guidelines instead of just a guidance. Do you think there is a future for this? I hope my question is clear.
It was very clear, and I know Dr. Serlin is online. He may be able to better speak to that aspect of it. To my knowledge, the AASLD did adopt a LI-RADS, so if their group is using the AASLD, it should be using LI-RADS. But as far as joint papers, I don't know the specifics of those, and if somebody else on this call can actually take that question, that might help.
Yeah, hey Bob.
Yeah.
Bob, this is Claude. First of all, yes. I just want to say I think you just gave a fantastic lecture. So bravo to you. Thank you for sharing your vision of LI-RADS. I really learned a lot and appreciate your approach. And I would love to have a copy of your PowerPoint. So first of all, congratulations. Would also, again, just like to congratulate Khaled for his tremendous job in putting this lecture series, and the amount of effort and work he's had to do is just phenomenal. And as many of us know, we ran into difficulties yesterday with a hacker, but Khaled, you've just been extraordinary. Frederica, I'd like to address your question. You raised a very interesting question. I was on the writing group for the AASLD from 2015 to 18, and we came up with our guidelines and guidance in 2018. We made the decision that it wasn't just us, it was throughout the AASLD, a decision was made that there are certain things for which there's high-level evidence, and there's very few things for which there's high-level evidence. But in the very few things when there's high-level evidence, we should have guidelines. However, if we only published guidelines, the vast majority of questions, the vast majority of clinical scenarios, the vast majority of clinical challenges will be unaddressed because there is high-level evidence for very little. So for things for which there is some evidence, but not enough evidence to be in the guidelines, the AASLD came up with the concept of guidance. Now, please understand that the concept of guidance versus guidelines is relatively new. And if we were to go back to 2001 with the very first EASL guidelines or the 2005 AASLD guidelines, we would not call them guidelines because there was not very much evidence at all for the recommendations that were called guidelines by EASL in 2001 or by AASLD in 2005 or 2010 or 2011. And I would argue that even the current EASL guidelines don't really have a lot of evidence behind them. So yes, I understand that EASL calls their recommendations guidelines, but if you look at their evidence very closely, there's not a lot of evidence for it. So yes, we need to move from guidance to guidelines, but we can only do that with evidence. And Bob Marks very eloquently provided a vision for how we can collect that evidence. But I would argue that that evidence applies not just to LI-RADS, it also applies to the current EASL quote-unquote guidelines. We as a global community need to collect the evidence to shift to true guidelines. And as Bob Marks said, we don't care whether the final system is called LI-RADS or called something else, but we should all be open-minded, self-critical, and in pursuit of the highest level evidence. So back to your immediate question, yes, we need to collect the data so that we can honestly call LI-RADS a guideline. But please, in a way that does not hurt any feelings, please invite, maybe we should do it this way, invite your hepatologists to join us in conversations and dialogue so that we can develop the evidence that your hepatologists would like to feel comfortable in the use of LI-RADS. We invite them to join our international consortium to collect the data that is needed. I hope that has answered your question.
Yes, sure. Thank you very much.
Thank you. We have another question from Jumbo. Is it your real name, Jumbo? Do you wanna give it? Okay, so I think I would just to give the question or read it for you. There's a question from Jumbo. Does LI-RADS define public policies for procurement agencies in US? I mean, do they require a report with LI-RADS to give priority of allocation organ? That's a question.
Okay, I understand. And so we're talking about, in America, we have OPTN. Now, I personally don't work at a transplant center, but as I understand it, and you can correct me if I'm wrong, LI-RADS 5 doesn't always mean an OPTN 5 or vice versa. I don't know which one it is. But I believe the Oregon Procurement Transplant Network actually has to have an OPTN 5 or what they call definite HCC, which may not be in concert with LI-RADS, but it's fairly close. But I think it's ruled by the OPTN, it's not necessarily by LI-RADS.
Can I add something?
Of course,
Yes.
Dr. Cherniak.
So I'm gonna add a perspective from a transplanted center. It's true that in general, Optum requires their own system, but when you use standardized reporting with LI-RADS, which clearly states which features are present, the OPTN reviewers or auditors actually prefer that because then they have all the details and they can assess whether or not everything was applied correctly. So we are a large transplant center. We do a lot of transplants. We only use LI-RADS. We do not even bother converting to Optum, and all our audits go through very smoothly with a lot of actually praise because it's so easy for auditors to make sure that everything is done correctly. So that's another way to encourage the clinicians to adopt LI-RADS is to adopt standardized templated report, which makes reporting very clear. So that's one of the tricks that we've used to adopt LI-RADS.
You know, hey, Victoria, that's an excellent comment, and that's something that You know, for Federica, that's something else that you could mention to your hepatologists, is that it would be very easy to convert a LI-RADS report into an EASL binary assessment. So if EASL, for example, only recognizes arterial phase hyperenhancement and washout, but does not recognize enhancing capsule appearance, if the radiology report clearly articulates the imaging features that are present, it would be very easy for the hepatologist to convert the radiology report into an EASL determination. So Victoria, thank you for mentioning. I think that's an excellent point.
Thank you very much. So Jumbo is like Dr. Hipperman from Argentina, actually. And that's why I was telling him, is this your real name? He said, no, I'm Diego Hipperman. Okay, great. So we have another question from Sandeep. Sandeep, do you want to give the question?
Hello.
Yes.
Hi.
Good morning. Good morning. Hi. I just
Good
wanted to.
afternoon, Sandeep, 1 second, because I like to make the personal connect here. So Sandeep, where are you from?
I'm from New Delhi. I'm from India.
Oh, great. Nice having you, man. We appreciate
Thank you.
attending the session.
It's really been very nice sessions for the past few days, and it's been a great learning for all of us. I just wanted to make a comment that sometimes we get stuck in a LI-RAD 4 lesion, and if you look at the clinical scenario or the clinical picture that the labs that are available to us, the lesion is not classically arterial enhancing, but you feel that there is a hunch of a more likelihood of an HCC in such a scenario. Actually, you need to, even if the lesion is not LR5, you tend to go towards LR5 so that the patient management comes into the decision making, gets helped, especially in a cirrhotic setting, especially with resections / liver transplants on the table. So is it a possibility in near future that we can incorporate some kind of lab values as well in our LI-RADS, which may help in decision making?
That's an interesting question. There are current studies going on, and these are probably long-term goals, looking at liquid biomarkers or liquid biopsies, per se, looking at novel biomarkers for HCC. And so although it doesn't currently exist, a goal for the future, and I know I didn't mention this because there's probably like a ton of goals, is that these studies are going on right now. And they're probably in their very early stages, but hopefully in the future, you're right, hopefully there will be some sort of biomarker, whether it be from blood or urine or stool or from whatever, that will help us know if something is an HCC based on imaging, or help guide that management.
Right. Thank you.
Federica, I want to give you again the room to talk if you want to make a comment, right, Federica?
Yeah, thank you. I want to thank.
So it says Federica here, first of all, buonasera, Federica. Second of all, Federica is only thanking Claude. She's not thanking Bob or me or Victoria. She's thanking. She's saying thank you, Claude. Can I make a comment? Go ahead, Federica.
First of all, I thanked all of you before.
No, I'm just kidding.
And by the way, buonasera.
Buonasera.
So yes, so the main thing, I work in the same hospital of Professor Brancatelli, so you better know him, and more than me. And we use LI-RADS in our report. So they accept it, but the main thing they are asking us, and I'm talking, okay, we have Professor Brancatelli, and okay, we have to use LI-RADS, and that's it. However, that's not the same in other centers. And the main thing our hepatologists and other hepatologists are saying is that we need prospective studies. This is also what Bob said, and I want to thank him for saying this. And I think this is the good direction also to make them accept, because they told me that there are many prospective studies to accept the wash-in, wash-out, so arterial phase hyperenhancement and non-peripheral wash-out, but not for the other criteria. So I think that this should be also, I think, to consider even more than even before AI or other things.
Oh, sure. Oh, maybe Claude needs to speak. She's talking to you.
No. Please, I do have a comment, but Bob, please proceed.
Oh, I was going to say, you know, when the examples I gave for gaps in knowledge was just a sample. I mean, we can sit here and talk about gaps in knowledge for a lot because, as we said, LI-RADS is, you know, when it started was of expert opinion mixed with data and for congruency. And so it's going to take more data, you know, about, you know, the enhancing capsule and wash out threshold growth is another one that doesn't have significant data to back it up. So these things are all knowledge gaps, which are only going to fuel the future of LI-RADS. You know, LI-RADS is a evolving system and has been updated over time. And the reason it's updated over time is because of new evidence. And the more evidence we get, the better it's going to be. So you're absolutely right. There's multiple knowledge gaps that have to be addressed in order to make this, you know, as perfect of a system, which it probably, no system can be perfect, but as good as it can be.
Hey Bob, if you don't, I'd like to just say something. So Frederica, first of all, thank you so much for participating in all of our webinars, and thank you for teaching us how to pronounce buonasera, and thank you for actually, now I want to be serious, thank you for very honestly sharing feedback from your institution. This is very, very helpful to us. I would like, though, for you and for everyone in this call to understand something, that there actually is not a lot of prospective data verifying the combination of arterial phase hyperenhancement and washout. To my knowledge, there's only 1 or 2 prospective studies that have done this. And the first study that did this came out of Barcelona. In the Barcelona study, patients were first screened by ultrasound, and only the ultrasound positive nodules, in other words, nodules that are actually seen on ultrasound, were then evaluated with the combination of arterial phase hyperenhancement and washout. So the studies that have been done have really only validated the combination of arterial phase hyperenhancement and washout in the subset of nodules that are actually visible on ultrasound. What about the nodules that are not visible on ultrasound? To my knowledge, there is not yet any prospective data on that. So that's one thing. Another thing to keep in mind is that if you look at some of the papers that were written on arterial phase hyperenhancement and washout in the last 20 years, and you look at the actual examples that were provided in the manuscripts, often the examples of washout, there was no washout. If you look at the images, what there is there's an enhancing capsule. And the combination of the enhancing capsule created the visual optical illusion of washout, but there was no washout. So even the papers that have validated quote unquote washout may have actually been mistaken and thought they were looking at washout when they were actually looking at capsule creating the optical illusion of washout. If you're not following everything I'm saying, please don't worry, but please do not believe and do not let your hepatologist believe that arterial phase hyperenhancement and washout has been validated by extensive prospective studies. It has not. I'm not saying that I doubt it. I'm saying that the validation for arterial phase hyperenhancement and washout has actually come from the cumulative experience of radiologists around the world, that no one has shown that it does not work. And so, yes, we accept that it works, but it's not because it's been validated by prospective studies. And so I really think the vision we need is not just only to have prospective studies, as Bob said, but what we also need is to create registries around the world where we can actually look at our own experience and learn from our experience. And if I'm not making myself clear, I apologize, but I'll stop now. But Frederica, thank you so much for raising these very interesting questions.
So,
thank you very much.
thank you very much, Federica. I was just joking with you. So we have someone who's joining with UT Southwestern Radiologist. By the way, I know all of you guys, so you better say your name and just introduce yourself. David, is it David? David?
Yeah,
Oh,
that's me. David Spencer
okay.
from UT Southwestern.
I
Hi,
see.
everybody.
Oh, hey, David.
Dr. Marks, it was a fantastic talk. I learned a lot. I really do appreciate it. And I would like a copy of your slides as well. I really commend Dr. Serlin for creating a culture of not only homogenizing presentations on this topic, but also creating a culture of sharing these amazing presentations with each other so we can more effectively share the great work that we're all doing to our respective communities. So I just wanted to say from a comment earlier about, you know, applying kind of common sense outside of strict LI-RADS, and there, I think there is some caveats built in to, you know, looking at the final score and then going back and applying some common sense kind of methodologies. One thing that links back to your highlighting the lack of evidence and future directions is the combining, the thought of possibly combining major features from different modalities. So if, for instance, at our institution, if we find we're getting the same imaging features from the same modality over and over again, and we're trying to bump up an LR3 observation to LR4 or LR4 to LR5, we may try a different modality. And anecdotally, we have seen some hepatologists and even some radiologists trying to combine features from different modalities to try to help a patient in a certain way, you know, direct them towards certain therapies or even transplantation. So I think, for instance, if we're not seeing arterial phase hyperenhancement by CT or MRI, attempting contrast-enhanced ultrasound or vice versa, and maybe that is an area where radiologists can help guide treatment into what we feel should be the correct treatment. But of course, this does need validation and evidence. But I think that's an area of active interest and future study.
Thank you very much, David.
Thank you, David.
Any further comment, Claude or Bob or Victoria?
I'd like to just add one more thing. So David, thank you so much for your comments. I just want to also, you know, we'll learn more about management in upcoming lectures. I believe it's Don Mitchell who's going to speak on management. But please, I don't want anyone to believe, you know, that's on this call that only LI-RADS 5 can be treated as an HCC. That's not true. What is true is that, at least in the United States, we would not want to do a liver transplant on a patient for HCC who does not have a LI-RADS 5. So in the United States, and this may not be true in other countries, in the United States, if someone is going to have a liver transplant for treatment of HCC, we want to make sure that the patient has LI-RADS 5 and does not, for example, have a LI-RADS M or a LI-RADS TIV. However, let's say someone is not a liver transplant candidate for whatever reason. Let's say someone has very well compensated cirrhosis or doesn't even have cirrhosis and can undergo a hepatectomy. In that situation, you don't necessarily need to have a LI-RADS 5. You could treat a LI-RADS 4 with an ablation or with a hepatectomy. You can treat a LI-RADS M with a hepatectomy. You do not always need a LI-RADS 5. It's only in the United States, in the context of liver transplant, that you need a LI-RADS 5 for treatment. So one of the things we're hoping is that we start refining our management algorithms, reflecting patients' underlying health status, reflecting different regions, different priorities and different resources for treatment. So the treatment in China may be different than the treatment in the United States, may be different than the treatment in Italy for the same LI-RADS category. So the LI-RADS category is simply communicating what we think is happening, but the actual treatment can be potentially optimized for the particular patient in a particular country with a particular healthcare system.
Great, thank you.
No, that's a great comment, Claude. And I was going to say, because we do that in practice, we're not a transplant center, but we have a large population of non-cirrhotic chronic hepatitis B patients, mainly of a large Filipino population in San Diego that we take care of. And we see a lot of LI-RADS 4s that have gone on to partial hepatectomy or resection or ablation who've done well. So we routinely treat non-cirrhotic LI-RADS 4s, depending on patient characteristics and whatnot, but our interventional radiologist will absolutely treat these people as an HCC.
Great, thank you very much, everyone. So I'd really like to thank Bob for the great lecture and everyone for the great comments and great questions and answers. With that, I would end